Greetings from Salt Lake City, Utah in the USA. It is a privilege and an honor for me to present to you in your Edwards Syndrome Awareness time period and month. I am Jonh Carey, a pediatrician and medical geneticist on faculty at the University of Utah. As you may know, I have a deep and career-long interest in chromosome syndromes, but in particular, the Edwards syndrome or trisomy 18. As most of you likely know, the trisomy 18 part refers to the chromosome change that causes the physical pattern or the physical condition with its challenges known as Edwards syndrome. This condition was described by Professor John Edwards from the United Kingdom in 1960. More on that. As you probably also know, treatment and management of children, especially newborns and young children with trisomy 18 and even related conditions like trisomy 13, is quite controversial. I can really only speak for the US and Canada and a little bit for Europe. But the reasoning process is because of the medical issues and the issues about survival, the traditional view has been to withhold treatment and to have pure comfort care as the approach to management. More on that as well. I'd like to say a few words about the history of trisomy 18 and also about my close connection with the support organization for trisomy 18-13 and related disorders, SOFT, of which I am the medical advisor and also on their board of directors. In terms of history, Professor John Edwards was working at Oxford University in the United Kingdom in 1959 when he was called to see a young girl who at the time was a few weeks of age. And he told me, since I got to know Professor Edwards, that her name was Sarah. When he saw Sarah, he recalled the fact that just recently it had been determined that Down syndrome was due to an extra chromosome. So thinking the same perhaps about her condition, he obtained a blood sample in that hospital, went back to Oxford, worked with his cell biology colleagues, and they detected that there was, in fact, an extra chromosome. At that time, they couldn't distinguish the various numbered chromosomes, so they called it trisomy 17-18. But now, of course, we know that the extra chromosome in Edwards syndrome is the number 18. I got to know Dr. Edwards over the years. He was one of my mentors. He came to a SOFT meeting in 1990 in St. Louis, Missouri, and I got the chance to know him even better. During the famous balloon release of SOFT, Dr. Edwards released a balloon for Sarah, which I thought was a quite stirring experience. Now, in regards to my connection with SOFT, I moved after my training to the University of Utah in 1979. Soon after, one of my colleagues referred a 2-year-old patient who, for them, surprisingly, was doing well and thriving. Her name was Carey, coincidentally, not spelled like my name, but similar, and her mother was Chris. And Chris and I realized in 1979 the potential importance of having a support group, an advocacy group for families of children with trisomy 18 and also the related conditions I mentioned, trisomy 13 and other chromosome conditions. And thus SOFT was created. The first gathering was in the spring of 1980 when 5 children attended. And then SOFT grew from there. And in 1987, the first conference was held, and I've had the privilege and honor to have attended every conference since 1987, And in fact, most of the conferences are accompanied by a clinic where specialists in that particular area see the families. This year, there will be a conference. We will have an in-person conference, SOFT, in Virginia, in Roanoke, Virginia, in the middle of July. Of course, everyone listening to this is welcome. And on the SOFT webpage, trisomia.org, information about that meeting is there. But of course, I recognize the challenges of traveling nowadays, especially traveling all the way through another hemisphere to America. But we will have our first in-person meeting since 2019. The last two meetings have been virtual, and I had the chance to participate. And the talks from those virtual meetings are actually available on trisomia.org in case anyone is interested. So going back to this controversy about care, the current model of care in America and also in most of Europe, including the United Kingdom and changing in Japan, has been this idea of comfort care without intervention. That is kind of what we might call a non-interventionist approach or hands-off approach, so that ventilation and the rest are usually not applied. And at least in America, more than half of all families of live-born newborns with trisomy 18 choose that particular path of no intervention because it seems to be kind of the traditional approach. But that is changing. It's really been changing in the U.S. since probably 2005, 6, 7, around that time, when it started to be that families were advocating for more intervention, including even in some cases cardiac surgery. And now we even know of multiple studies around the world, Japan, the United States, Canada, about heart surgery in children with trisomy 18. Something I'm happy to talk about if people are interested. The other changes that are occurring are that we know that there are more hospitalizations of children with trisomy 18 than there were in the decade before, 2001, 2005, 2006. We also know that there are not only more surgeries related to the heart, which surprise people, but also other surgeries, including when the various parts of the bowel are blocked, or even putting a tube in the stomach, what we call in America a gastrostomy, probably similar in Portuguese, in children who are having feeding difficulties. But I think part of what led to this change that's occurred primarily in the last 20 years has been the medical profession working more toward patient-centered care and shared decision-making. But a lot of what made that happen were families advocating for their infants. That led, I think, to this change in model, to the change in the narrative, the change in the story. So just to relate, I think I've been quite pleased to see that over the last 10 years, there's been much more research in trisomy 18 and related disorders. Not only are these studies about cardiac surgery, but there are studies showing improved survival by 1 year of age compared to what was known prior to let's say, 2010 or 2012. There's also been studies actually showing that parents' stories indicate that they consider their children to have a very high quality of life. And Dr. Jonh from Canada has 5 papers on this topic, which I think really has changed a lot of views. There are also more papers on ethics, sort of suggesting that in areas of uncertainty, like in the care of trisomy 18, that it is best to err on the side of the parent's view. So that's been the trend that's occurred in America, even though, as I mentioned earlier, the majority of families frequently go down the path of no intervention. Nowadays, that's a lot more humanistic and caring because we do have a very excellent network of pediatric palliative care in North America. That's, even with those families, it's been a better path. So I actually am optimistic about future research. I'm working with some colleagues of mine at the University of Utah and actually around the country, around America. And we're trying to put together a study that observes a few hundred children over a 2-year period with trisomy 18 and also with trisomy 13, and exactly what happens in real time. We're hoping that will give us a better perspective on what's becoming clear, that intervention, that is intensive therapy, ventilators, etc., surgery, do improve survival. So I would like to close, say obrigado. Oh, sorry for my pronunciation, obrigado. But I wish everyone the best in this Edwards Syndrome Awareness Month to all of my friends in Brazil.